This is an example of a gel stent case where it initially looks like the implant is not embedded in Tenon's tissue given the thin conjunctival appearance. However, once we dig in a little bit deeper, we can see that there is still impedance from the Tenon's tissue that does need to be addressed in order to try to maximize the placement. After the inserter is placed through the sclera in an area where there are no blood vessels, that's where the traction suture is placed in order to try to maximize the positioning of the implant to where we don't get a subconjunctival hemorrhage. The bevel is forced all the way through the sclera until we see the back wall of the bevel before the injection begins. And if you look really closely, you can see that the implant is slightly bent underneath the sclera. That tells you that there is Tenon's tissue around it. So after we remove the viscoelastic, we actually see a tense bleb that forms. And this is more common when we see a focal anterior bleb due to more of a subtenons or intratenons placement. And this is probably due to peritubular flow, because if you look closely, there's an air column inside the implant, which is very normal to see. Generally, manipulating the implant like this does relieve the air bubble, or if you wait after priming it, it does also move through the implant generally within the first day post-operatively. I do like to use balanced salt solution on a stick to pressurize the anterior chamber to increase the pressure in order to relieve these air columns. I do like to look to see how that implant's positioned. I want to make sure that it is truly subconjunctival, and I think the vast majority of these, even though it looks like it's placed in a really good superficial portion, you do need to do what we call primary needling in order to relieve the implant from the Tenon's tissue. I like to raise the bleb so it reduces the chance of perforation through the conjunctiva, and also reduces the chance of hitting the scleral vessel to cause a subconjunctival hemorrhage. For the primary needling, I like to use either a 27 or a 30 gauge hypodermic needle on a 1 cc syringe. I like to enter far away from the implant to avoid a bleb leak, and it's important to use the fulcrum within the tissue so you don't tear the tissue. I work distally, the furthest place of the implant away out of the sclera, and then work the needle back toward where the implant exits out of the sclera to avoid pulling it all the way through. I continue to sweep and fulcrum in that subconjunctival space until things are really free. And really what I'm trying to do is go underneath the implant initially and then over the top of it, and again starting distally and working my way back to where it exits the sclera. When I create what we call this space, essentially, or freeing the implant from the Tenon's tissue, I like to do this until there really is no manipulation of the implant whenever I'm sweeping the Tenon's tissue. Generally, if it's still caught in Tenon's, it will move as we start to strip away the Tenon's from around the implant. I will still then go back and check the mobility of the implant. I like to move the implant side to side, and if it likes to spring back into its original position, that tells me that it's still caught on some Tenon's tissue, and generally then we're going to go back in and try to free it up, because our endpoint really is to have this implant purely free where it's not springing back due to being engaged within the Tenon's tissue. So we'll go back in with our hypodermic needle and again needle that space until there is no tissue resistance. And I think this is probably one of the more critical portions that has really reduced our needling rates down to around less than 10% in the post-operative course. And I think a lot of this was due to the fact that we are freeing the device from the Tenon's resistance that does occur if you just place this into the subconjunctival space. Now, once we feel that it is completely free and we have addressed it with an antimetabolite, we'll remove our traction suture and have the patient look down in order to prevent the implant from shifting when we remove the speculum.